everyone, I'm back and we're going to talk about schizophrenia and our schizophrenia spectrum type disorders. I again will do a separate video where we'll be going over medications. So for now, just schizophrenia. So schizophrenia is a young person's disease. We tend to see onset in men between 15 and 25, women 25 to 35. New onset psychosis in 40s, 50s, 60s, 70s is not usually indicative of schizophrenia. Could happen, but super tiny, small chance. They're very rare. Even in childhood, early 10 is very rare, but again, can happen. Comorbidities, there's a ton. We tend to see this with substance abuse, and that's kind of a which came first, chicken or the egg. Some of our substances like marijuana can start schizophrenia. Sometimes the substance abuse is being used, right medication. We're self-medicating. Depression, suicide, physical illness, lots of cardiac complications with schizophrenia. These individuals have a life expectancy about 20 years less than the general population. When we talk about genetics, it is a huge component. We talked about a few examples. We looked at Cody Green, one of those YouTube influencers. His mother had schizophrenia, and then all of a sudden he's like, hey, wow, look, what is going on with me? The other thing that we tend to see with that, 6 schizophrenic brothers, a family of 12 where 6 of them had schizophrenia. I have seen this in some of my friends where if you have a family member, excuse me, I got all the sneezes today. If you have that family member, that first degree one, especially with schizophrenia, you are more likely to have a higher chance of developing schizophrenia yourself. So we have to assess for that family history. Increased dopamine. Dopamine is our neurotransmitter associated with schizophrenia and hallucinations. Prenatal stressor. If you have influenza during the second trimester of your pregnancy, that child now has a greater risk of developing schizophrenia. And we see this when we look and when we track those born in late winter, early spring, tend to have higher rates of schizophrenia because of that. And then if we have a father older than 35, we tend to see these new onset psychosis at time where stress is higher. So, college, moving away from family, after abuse and after trauma. We do have a risk associated with environmental stressors and toxins. We see higher rates of schizophrenia in those who live in more urban areas, pollution, dry cleaning, fluids and substances. Exposure to those all do increase your risk of developing schizophrenia. So one of the things we have to think about is in schizophrenia, many of these cases are not going to respond to treatment. We have some individuals who are having these symptoms, especially the delusions, the hallucinations, they are going to carry on and continue for forever. They just learn to live with them. Some patients don't learn to live with them, and they are just kind of stuck with this forever. You do tend to have a worse outcome if you are diagnosed at a younger age and if we delay getting treatment. The more frequently we are getting treatment, the more frequently we're reaching out, the better the outcome. We have a few different phases of treatment. The prodromal phase is this early onset that we tend to see. We tend to see changes in mood, a lot of those negative symptoms. We're not doing as well as work. We're not hanging out with friends. We're slowly just withdrawing. That often starts to get overlooked, especially because when we're talking about those adolescents, the guys, we tend to think this is just part of adolescence. After that, we get to this acute phase, and that is where we tend to see that psychosis and those hallucinations, where the patient is actively hallucinating. We are definitely functionally impaired. We do need extra support. We may be hospitalized at this time. Regardless what happens, eventually this patient can stabilize and kind of get to an okay level of functioning. But what happens is our patients tend to go like stable, acute, stable, acute, stable, acute, and they can go back and forth. If we can get our patient into good, solid treatment, we can get that new baseline established, and that is that kind of maintenance phase. I'm taking my meds, I'm going to the doctor, I'm able to recognize what is a hallucination, what is not, and we can do okay. Now, we have a few different types of symptoms in schizophrenia. We're only going to focus on 2 of the categories in this class right now, and that's positive and negative symptoms. So when it comes to positive and negative symptoms are not good. They do not mean positive like good. They mean positive like in addition. These are symptoms that a person has that we don't want. These are things that a normal person does not have, but we are adding into that person with schizophrenia. I also tend to think of it as positive symptoms are our psychotic symptoms. So this is going to be an individual who has psychosis. They have delusions. They have hallucinations. They have strange speech. They're not able to think abstractly, right? They're not able to determine what is real or what is not real. These, again, can be very disabling to our patients. We watched a little schizophrenic stimulator. The other type of symptom we have are negative symptoms. Negative symptoms are the absence of normal human qualities. So these are things that we don't have, but we want. So when we're talking about negative symptoms, we tend to think are our A words. As we can see, there are a lot of A words, but we need to know the definition of these. I'm hitting buttons today all over the place. Anhedonia, lack of pleasure. Things that used to give us pleasure no longer do. Avolition, lack of motivation, loss of motivation, inability to have goal-directed behaviors. And when we're talking about goal-directed behaviors, that is not like I'm going to go to college. Goal-directed behaviors could be something as simple as I'm going to get out of bed and take a shower and then go to work. Asociality, that is that withdrawal. We stop hanging out with our friends. We have a decreased desire. We don't get comfort from social interactions. Affective blunting, our facial expressions is not going to be as vast. We tend to have a decrease in the amount of facial expressions. Apathy, interest in things that otherwise would be important. We have someone who always used to love, music, and now they're not listening to music anymore. Alogia is sometimes called poverty in speech, and that is a reduction in speech, no speech. This is one that can be good to remember. No speech is a negative symptom. Strange speech is a positive symptom. So now that we've talked about all of those, we are going to go over what are our schizophrenia type disorders. So we have a few different types. Delusional disorder is just what it sounds like. We have delusions and nothing else. And those delusions don't always affect our ability to function. These are individuals who might believe that the CIA is out to get them. Maybe they're wearing tinfoil on their head, but they're still going to work. They still kind of have friends. Brief psychotic disorder is what it sounds like. We go psychotic, but it lasts less than a month, and then it just goes away. Schizophreniform disorder, very much like schizophrenia, but it only lasts 6 months. After 6 months, it goes away. Those with brief psychotic disorder and schizophreniform disorder, they can return to their previous level of functioning. They can struggle. They can later develop schizophrenia. Schizoaffective disorder is schizophrenia combined with a mood disorder. Now, our mood disorders are depression and bipolar. So this is someone who has a diagnosis of schizophrenia and bipolar, or schizophrenia and major depressive disorder. So sometimes we see like schizoaffective disorder, current like state manic. And it will specify our patient has schizophrenia, but they're also manic. This is a really hard one because we're now having to manage multiple different things. So we can kind of see we have our brief psychotic disorder. It's going to last less than a month. Our schizophreniform disorder is 1 to 6 months, and schizophrenia is greater than 6 months. So in schizophrenia, these symptoms are occurring, that prodromal, that active phase, for 6 months or more. So what do we do when we are working with a patient with psychosis? Well, if they have poor hygiene, I need to work with them to shower. Resistance to treatment kind of goes hand in hand with resistance, cheeking or palming medications, and that anosognosia. Anosognosia is that kind of state that we tend to see in mental health where our patient does not recognize that they have a mental illness. So if our patient does not recognize that they have schizophrenia, and maybe they're delusional and they think that we're working for the CIA and someone's trying to poison them, we're going to see them cheeking or palming medications. We very much have to work to form a relationship with this patient, get some medications on board, and we definitely have to be doing some like mouth searches. We need to watch our patients take the medications. Sometimes we can do IM versions or sublingual versions for our patients who are a little bit more concerned. Our patients may avoid peer interactions, and that goes a lot with that asociality. And it's hard because we want them to have these relationships. So what we may have to do is like get them into a group therapy session. If our patient is depressed, we're going to take safety risks. I'm going to assess for depression. I'm going to take away sharp objects. Same thing if I have a patient frightened and they're a fall risk. I'm going to make sure they're in their grippy socks. I'm going to make sure that there's nothing on the ground. Fall risk often is one of those priority interventions for our bipolar and our schizophrenia patients, along with choking, right? They're eating, they're doing things, they're just kind of not thinking about it. Restlessness and agitation, we want to be able to form a relationship and see what is going on with them and be able to intervene early. Keep our patients, right, a nice little dose of medication, be able to have that relationship to de-escalate them. Other directed violence and self-directed violence, very similar to bipolar or agitated patient, but with a mania. We have to have that relationship. We have to be aware of it. Keep away sharp objects. And we'll talk with our hallucinating patients. One of the things we do have to look out for in that other and self-directed violent are those what we call command hallucinations. So we sometimes can see our patients hallucinating. You can take someone and they're sitting at a table and they're carrying on a conversation and talking to themselves, even though no one else is there, right? They're looking around, they're often getting distracted. We have to talk to this patient about the hallucination. What are they hearing and seeing? And it gets tricky because we don't want to talk too much about the hallucination, but the priority is a command hallucination. Are they telling you to do anything? And that kind of goes hand in hand with the risk for other and self-directed violence. We have to take all those safety precautions. However, one of the big ones are assessing the hallucinations. If the voices are telling them to kill someone, we're going to need to know that. If the voices are telling them to kill themselves, we have to know. And hallucinations can make our patients very anxious, and we really just have to be empathetic. We can't tell them that it's not real because to the patient, it is real. If they're seeing bugs crawling all over the walls, then they are seeing bugs crawling all over the walls. That is what it is. We can't tell them that no, there is nothing there. I don't hear the voices, but I do believe you do, and it must be scary. Try to focus on what is going on in the moment. Reality testing is hard. It is something we can do if we have a more stable patient. And I think it was one of the weeks at Clinical with y'all, we had a patient and she's like, I don't think like I really have all this power. Like, I don't think I'm God. And whatever it is, she had started to question these delusions that she was having. That is that reality testing. We talked about Cody Green. We talked about how he uses Luna. He has a schizophrenic service dog. And he's learned if my dog does not interact with someone, then I must be having a hallucination. Again, stress reduction, those basic life, eating and sleeping are going to be extremely important. We want to be able to connect this person with other people, with support systems. NAMI has a whole bunch. Contact the family, right? Have a set and develop plan for what it is that they can do. Our patient who is delusional is a little bit different, but a lot the same. With hallucinations, we're directly going to ask, are you hearing or seeing things? Oftentimes with someone who has delusions, we're not going to ask them, are you delusional? It just does not go over well. We want to be able to have that trust with our patient so they talk to us. Oftentimes just listening to your patient, you will be able to know they're having delusions. And you will be able to pick up on what the delusion is. Again, matter of fact, empathetic. We cannot debate if they think the CIA is out to get them. We cannot tell them that the CIA is not out to get them because their response is going to be, well, you are working with the CIA then. Again, reality-based, talk about what is going on in the here and now. In that validate parts that are real, we can definitely tell them, like, listen, you're in the hospital. Like, you are here at Cross Creek. You are surrounded by nurses and doctors, right? We're telling them exactly what it is. Again, we have to acknowledge it is real to the patient, and we can let them know that is real to you, but that is not real to me. I will always caution y'all, each patient, each set of psychosis, each set of delusion is going to be different, and how we respond to it is going to be different. Again, we want to focus on reality and reality testing. We are going to lunch now. We are going to the gym. MedPass will be at this time, and then we will have group at 2 o'clock. In that patient and family teaching, we have a bunch of different resources. NAMI is one that our patients can use. As healthcare providers, we're going to want to talk about support system, medications, weight, diet, exercise, overall physical health. Staying healthy, sleeping well, decreasing stress can lead to better outcomes in the long run. Support groups are amazing. Peer counselors, all of these individuals exist. We need to make sure that we are staying up to date and knowing what is going on to better be able to work with our patients. Again, I'm going to do a separate medication visit video for you, so I'm going to skip through a lot of these. And honestly, I think that is it. So I will have schizophrenia super short, 15 minutes. I will have a separate medication video for y'all coming up soon.